Hello guys, I welcome all of you to today's Pharmcast. I'm Dr. Ranjan, your pharmacology faculty at Marrow. And in today's Pharmcast, guys, we'll be talking about cardiovascular system. We'll revise briefly what are the PYQs that have been asked and what you need to focus based upon the book One Touch Pharmacology for revision. Now, cardiovascular system, the beginning topic, the first one that is on page number 19 in One Touch Pharmacology is antiarrhythmic drugs. In one page we have antiarrhythmic drugs, and see, in antiarrhythmic drugs, class 1 sodium channel blockers, most of the times, 99% of times, what they ask you is about which of the following drug can cause QT prolongation or torsades. So if you look at the last 5 years PYQs, this is the MCQ which has been asked most of the times, and always your answer is quinidine, right? So somehow they are hooked to quinidine. And I've told you in my classes how to remember this. At least you can remember one drug that causes QT prolongation. And how is that? Q for QT prolongation, Q for quinidine. And the most recent MCQ was an image-based MCQ asked in the last exam. There was an image of a graph after giving the drug. There is delay in repolarization, right? So if there is a delay in repolarization, the graph becomes wider. And they had asked you which drug has caused this. Your answer was quinidine. So QT prolongation or torsades can be seen with two classes of antiarrhythmics, class 1A and class 3, two classes, right? And class 1A quinidine, class 3, these are potassium channel blockers. Second, they can ask you which potassium channel blockers has the least risk of torsades, and that is amiodarone, right? So these are the MCQs which they ask you. Second, they can ask you what is the drug of choice for WPW syndrome, and that is flecainide. All of us know that, but it is less commonly asked nowadays. Third, the MCQ they ask you from class 1 antiarrhythmics is about lidocaine, and they ask you what is the drug of choice for ischemia or myocardial infarction or angina induced VT or ventricular fibrillation, and your answer is lidocaine. And though we can also use amiodarone, and nowadays amiodarone is also commonly used for MI, angina or ischemia induced ventricular tachycardia. Second, they can ask you what is the drug of choice for digoxin induced ventricular tachycardia or fibrillation. Again, your answer would be lidocaine. Class 2 drugs, beta blockers, they are not that commonly asked, though there are lots of drugs of choice here, right? One they ask you sometimes is if it is pheochromocytoma causing arrhythmia, what would be preferred? Then I'd go for beta blockers. Now coming to class 3 drugs, now what is that they ask? They love to ask about class 3 drugs. If you go through the last 5 years or even 10 years of PYQs in class 3, invariably, most of the times, the single drug which is asked commonly is amiodarone. Amiodarone, which is drug of choice for VT, VFib overall, and it is also drug of choice for rhythm control in atrial fibrillation and flutter. But if you look at the uses, they are not asked nowadays, right? So what they ask you about is about the side effects. So you can see here in the page number 19, I have marked side effect in red color. SE is side effect in red color. That means everything has been asked. Now coming to what are the latest MCQs they have been asked. The most latest MCQ which was asked was about, it was an image of a person, right? A person was given a drug, and the image was given where he had, his face was bluish grayish, right? Pigmentation was there. So this blue gray skin pigmentation of sun exposed area, which is also called as ceruloderma, is caused by amiodarone. Apart from this, the second MCQ which has been asked in recent times is about pulmonary fibrosis, right? So which of the following drugs, they are given you 4 options, can cause pulmonary fibrosis? Again, your answer was amiodarone. So I've given you all the different side effects of amiodarone. Please go through them. Now class 4, calcium channel blockers, verapamil, diltiazem. What is that they ask you? They love to ask you. They've asked many times in the last 5 years. There are two types of MCQs actually. One MCQ that asked you, verapamil is a drug that should not be given with which of the following drugs, right? And your answer was a beta blocker, right? Or it can be asked inversely, like a beta blocker should not be given with which drug? Your answer would be diltiazem or verapamil. That is one type of MCQ that has been asked. A second type of MCQ that has been asked is why a person on beta blocker should not be given verapamil? What is the reason? And the reason is conduction block. Yes, the reason being both are Both beta blockers and verapamil or diltiazem are blockers of AV node. And if I combine both, they can cause total conduction block asystole. A patient will die. So these are two MCQs which are asked. Now coming to class 5. Now if you look at the class 5 drugs, we have drugs like adenosine, which is the most commonly asked drug in class 5. And what is that they ask you? Yes, here they ask about uses. And what is it that adenosine is drug of choice? And all of you know that it is the drug of choice for an acute attack of PSVT, paroxysmal supraventricular tachycardia. That's one MCQ. Second MCQ, if you look at the last 5 years, they've asked, this was an MCQ, they had given you an ECG of atrial fibrillation. An image was given, right? And they had asked you, which of the following drugs should not be used in this patient? And your answer was adenosine. Now it's surprising. Adenosine is an AV nodal blocker. Still it is not used in atrial fibrillation. The reason being, adenosine itself can cause atrial fibrillation, right? Apart from this, in antiarrhythmics, other drugs are not that commonly asked. Sometimes they might ask you what is the drug of choice for bradycardia, and all of you know what the answer is atropine, and the dose has to be more than 0.5 milligrams. The reason being, lesser than 0.5 milligrams, atropine itself can cause paradoxical bradycardia. Right guys, right. Let's move on to page number 20. And in this one page, in page number 20, we talk about congestive heart failure. And congestive heart failure, see acute and chronic CHF. So what are the MCQs they can ask you? See, acute CHF, the MCQs have not that commonly been asked in the last 5 years. So mostly the MCQs are about chronic CHF. Anyways, but if acute CHF, if at all they ask an MCQ, they'll ask you about how do I manage acute CHF? Remember, the treatment of choice for acute CHF is a combination of two drugs. One is a diuretic, that is furosemide. Second is an inotrope, that is dobutamine. So acute CHF, furosemide plus dobutamine is what I prefer. Now coming to chronic CHF. So what are the MCQs they have been asked in the last 5 years? So look at this MCQ, right? They had asked you, which of the following drug is used in heart failure, but it does not act upon the heart, right? And your answer was captopril. So captopril is an ACE inhibitor that is used to decrease mortality, but you know that it does not act upon the heart directly. So in chronic CHF1, you have to remember which are the drugs that decrease mortality, and I've given you the mnemonic in the book in my classes. Shiva beta, right, is the mnemonic, and spironolactone, and there is one addition, SGLT2 blockers, hydralazine, ivabradine, vericiguat, and all these drugs. You have to go through those, right? Please go through them. Second, in heart failure, if you look at 90% of questions, they are from one single drug. Yes, one single drug. And can you imagine which drug is that? All of you know that drug. It has been asked umpteen number of times in our exams, and that drug is none other than digoxin, right? So everything becomes important for digoxin. But I'll talk about what they have asked in the last 5 years as MCQs and what they can be asked. One MCQ they had asked you is, a patient is on digoxin, and he was started on different drugs, 4 drugs, and which of these 4 drugs can cause toxicity of digoxin, they had asked. Your answer was clarithromycin. So remember, digoxin is a substrate for P-glycoprotein pump. So any inhibitor of P-glycoprotein pump like clarithromycin or erythromycin, they can cause digoxin toxicity. Second MCQ they had asked you, right, is based upon the pharmacokinetics of digoxin, that is, they asked you how much time does it require for digitalization. What does it mean? Is after starting digoxin, how much time would it take to produce effect or reach a steady state concentration? And that is 7 to 10 days, because the half-life is around 1.5 to 2 days. So you multiply that by 5, it comes to 7 to 10 days. Now, the most common MCQ that has been asked about digoxin is about side effect. The most common and earliest side effect is nausea and vomiting. Plus, they cause a specific color vision. Which one is it? You guys might recall, xanthopsia or yellow vision. It has been asked a lot of times, guys, right? Contraindications of digoxin are again important. Any condition that can increase risk of digoxin toxicity, and those are hypercalcemia, hypomagnesemia, hypokalemia, myocardial infarction, renal failure. Second, WPW syndrome. Third, HOCM. These are the contraindications. Please go through them. And third, again, the second most important MCQ, they ask you about digoxin toxicity. If you recall, in the last year, they had asked an MCQ that there is a patient and he was started upon digoxin and multiple drugs, and what happened is his serum digoxin level was high and he had signs of digoxin toxicity. And what should I be using for treatment of this patient? And in other words, they were asking what is the antidote for digoxin. And it's simple one, digibind, right? So digibind is the treatment of digoxin toxicity. Second MCQ they ask about toxicity is what cannot be done for digoxin toxicity. Your answer is dialysis. So dialysis cannot be done. The reason being it has a high volume of distribution. Another MCQ they ask you here about drug is sacubitril, which is also used in chronic heart failure. And sacubitril MCQ has been asked 2 years back is which of the following is an inhibitor of neutral endopeptidase or neprilysin? Your answer is sacubitril. Right, now let's move on to the page number 21 where we talk about vasodilators. See, vasodilators, first of all, atrial dilators, most MCQs they are asked upon calcium channel blockers. Calcium channel blockers uses are not that commonly asked. Nevertheless, there are two drugs of choice. Raynaud's disease, their drug of choice. Second, cerebral vasospasm secondary to subarachnoid hemorrhage. I prefer a specific dihydropyridine, that is nimodipine. What are the MCQs they have been asked in the last 5 years? It is mostly about two side effects. One is ankle edema. Ankle edema can be caused by calcium channel blockers. And so they asked you which of the following antihypertensive drug can cause ankle edema, CCB. What they can ask you here further is which class of antihypertensive can prevent CCB-induced ankle edema, and your answer would be ACE inhibitor, ARB. Second, they had asked you recently, last year, which of the following drug can cause constipation as a side effect? Again, it's a calcium channel blocker. It's a specific side effect of only one CCB, and that is verapamil, right? Sometimes they ask you about minoxidil, right, which is a drug that is used in topical route by androgenic alopecia. Your answer is minoxidil. Now coming to venodilators, guys, they do ask you sometimes about nitroglycerin, like which of the following drug undergoes high first pass metabolism. Your answer is nitroglycerin. This has been asked. And an easier MCQ is which of the following is drug of choice for an acute attack of angina. Your answer is again nitroglycerin. Now, nevertheless, here what you need to understand is that the other drugs, isosorbate dinitrate and mononitrate, they're less commonly asked, rarely asked. Only one point, guys. Only one point which you need to remember is which is the only nitrate that does not undergo first pass metabolism, and it is isosorbide mononitrate, right? Now coming to mixed dilators, the most important class here are Ras inhibitors. And Ras inhibitors, remember the one thing they ask you is clinical questions about use in hypertension. So they can give you MCQ, there is a patient of hypertension with either diabetes mellitus or chronic kidney disease or nephrotic syndrome. What is the preferred drug? Your answer would be a Ras inhibitor. But remember one point here. If in your clinical MCQs, if there are signs of edema, if there is edema, then your answer will not be Ras inhibitors or ACE inhibitor. Your answer would become thiazides in hypertension. So look for edema, right? Now, ACE inhibitors, two side effects have been asked. I mean, you cannot even count how many times they've been asked in the last 10 years. And even in the last 5 years, they've been asked. One is dry cough. Second is angioedema. ACE inhibitors, these are commonly asked, guys. Now, ARB are rarely asked. If they ask you, it is mostly about losartan. Now, losartan, there are 3 points. It increases uric acid excretion, so it can be used in hypertension with gout. It blocks thromboxane A2, so it has anti-aggregant effect. Plus, it stimulates PPAR gamma, so it can decrease insulin resistance. The most recent MCQ was which can cause a maximum stimulation of PPAR gamma. It is telmisartan, right? And coming to the contraindication of Ras inhibitors, there are two contraindications to Ras inhibitor, and one is pregnancy, second is bilateral renal artery stenosis. The most recent MCQ was like a pregnant female suffering from hypertension. A female is suffering from hypertension, and before she conceives, right, before she becomes pregnant, which class of antihypertensive should be stopped? Again, your answer was an ACE inhibitor that was given in the option, right? Now let's move on to the next page, page number 22, where we'll talk about some disorders like hypertension and angina. See, in hypertension, I've already told you, most MCQs in hypertension are clinical ones, right? So they'll give you comorbidities like if it's a case of hypertension with CKD, diabetes mellitus, I'll go for ACE inhibitors. If they give you there is a patient of hypertension with edema, then I'll go for a diuretic like thiazide. If they'll give you hypertension with BPH, I'll go for alpha blockers, and so on. Now, the one MCQ they have recently asked, and it has been asked many times, is the definition of resistant hypertension. So what is the definition of resistant hypertension? When the patient does not respond to at least 3 drugs, 3, yes, and one of them, it has to be a, which one guys? It has to be a diuretic, right? So diuretic was the answer which was asked recently, and it has been asked many times, right? You might find in pharma, you might find in medicine. Now, severe hypertension or hypertensive emergency, urgency, these are, rarely asked. But if they ask you hypertensive emergency or urgency, remember, the basic difference you have to remember is emergency, I use IV drugs, urgency, I use oral drugs. So whenever they ask you, which is not used in emergency, urgency, stick to the route of administration and try to find out the drug, which is the answer, right? Angina. See, in angina, if you look at the PYQs, most of the MCQs are on mechanism of action, yes. Right, for example, nitroglycerin's mechanism, they ask you what is the mechanism of nitroglycerin in stable angina. And remember, it is not coronary vasodilatation. That is not the main mechanism. In stable angina, the main mechanism is a decrease in preload on the heart due to venodilatation. Whereas in case of variant angina or prince-metal angina, the main mechanism is coronary vasodilatation. The other drugs which have been asked a lot of times is about drugs like ranolazine. They have asked you the mechanism of action. It blocks late inward sodium channels. Ranolazine blocks sodium channels. Ivabradine blocks funny channels. Nicorandil opens potassium channels. Fasudil inhibits Rho kinase. And trimetazidine blocks PFOX or partial fatty acid oxidase. That's all you need to remember. Now coming to page number 23. See guys, in page number 23, if you look at the topic is hypolipidemic and some MCQs they do ask you. Statins, the most important class of drugs are statins. And to begin with, see, what do I need to decrease in the lipids, the bad ones? Either I need to decrease LDL, or I need to decrease triglycerides, or I need to increase HDL. So just focus. If I want to decrease LDL, I have 4 options. Statins, bile acid binding resins, STMI, PCSK9 inhibitors. If I want to decrease triglycerides, I have one option, fibrates. If I want to increase HDL specifically, I have one option, that is niacin. That's one thing, right? Statins, what is they ask you? Number 1, mechanism of action is a blocker of HMG coenzyme reductase. Second MCQ, it has not been asked recently, but earlier they used to ask what is a pleiotropic effect of statins. So pleiotropic effect is effects which are other than the hypolipidemic effect, like anti-inflammatory, antioxidant, anti-aggregant, anticoagulant, plaque, atherosclerotic plaque stabilization, release of nitric oxide causing vasodilatation. So these have beneficial effect, cardiovascular beneficial effect, but they are not related to LDL. So they are called as pleiotropic, right? Uses they don't ask because everybody knows what is the use of statins and all, right? But one MCQ they have asked you is what is the drug of choice for type 2 hyperlipoproteinemia? Your answer is statins. Now some pharmacokinetic aspects of statins are important, like which is the most potent and longest acting statin. They ask you, and most of the times your answer is rosuvastatin. Remember, most potent and longest acting. Second, they ask you, when should I give a dose of statin? What should be the timing of statins? It is night time because the enzyme activity is maximum is night time. And then they ask you which statin can be given in the morning hours as well. And this has to be the long-acting statins like rosuvastatin and atorvastatin. Third point, you have to remember that statins are metabolized by cytochrome P450 enzymes. And that is why enzyme inhibitors can cause statin toxicity. Now coming to a recent PYQ that asked, which of the following drug can cause toxicity of statins? Your answer was clarithromycin again, because clarithromycin is an enzyme inhibitor, so it can cause toxicity, right? And so as I said, all statins can be metabolized by cytochrome P450 enzymes, except the only exception is pravastatin. Pravastatin is not metabolized by cytochrome P450 enzymes. So if they ask you which could be safe with enzyme inhibitor, it would be pravastatin. Side effects of statins, there are 3: myopathy, hepatotoxicity, insulin resistance. But remember, we do not monitor. It causes hepatotoxicity, but I do not monitor LFT. But I do need to do a baseline LFT. Like I need to do LFT before starting statins, right? But I do not need to follow up with the LFT. Now coming to bile acid binding resins, see, all hypolipidemic drugs, they are not safe in pregnancy. The only class that is safe in pregnancy and children are bile acid binding resins. So that's the only thing that is in use they ask. Second thing they ask is about a side effect, that is hypertriglyceridemia. So see, bile acid binding resins are hypolipidemics, but paradoxically they increase one of those lipids, that is triglycerides, hypertriglyceridemia. Now coming to estimide and PCSK9 inhibitor, the only MCQ that has been asked in the last 5 years is upon the name of the drug. Which of the following is a blocker of NPC1L1 or Niemann-Pick1 like 1 receptor? Answer is estimide. Last year they had asked, which of the following is a PCSK9 inhibitors? And your answer was evolocumab. There are two drugs, evolocumab, alirocumab. Now moving on to fibrates. See, if you look at fibrates, fibrates, MCQs have been asked upon the mechanism of action. What do they stimulate? They stimulate PPAR alpha. Fibrates are stimulator of PPAR alpha, and they increase lipoprotein lipase, right? And their drug of choice for hypertriglyceridemia, that is one MCQ which is commonly asked. And side effects, the only side effect they ask is about gallstones. They do cause gallstones as side effect. Niacin is rarely asked, but the one MCQ which has been asked recently was hepatotoxicity and flushing. Niacin can cause flushing, for which aspirin is the drug of choice. So guys, this is all we had to discuss in cardiovascular system. So I told you, right, what is the most frequently asked MCQs from cardiovascular system I've discussed, and try to revise this. Now before, in every Pharmacast, what I do is before I wrap up with the Pharmacast, I talk about one of the doubts of any student who has asked me in the last 1 week. Right, so in 2 or 3 days back, I got a message from a student, an FMG student, that sir, as the exam time is nearing, I mean, the 20th of Jan is FMG exam, and he's telling that as the exam time is coming nearby, I have a feeling like I'm forgetting everything, and I don't know what to do in the last 10 days, and I cannot revise everything in the last 10 days. So what should I do? Now see, so he has two doubts basically. One thing is the feeling of forgetting everything while the exam is coming near. Now it happens to everybody, believe me. The reason being, when the exam is approaching, the anxiety hits through the roof, and some people, they're so anxious because see, all of us, we are different human beings. We are not alike. So how I might react to a situation, you might not react in that way. So some people, they develop anxiety which they can control, and some develop anxiety to such a level that it affects their preparation, that then you need to consult for some medical help, right? It's okay. I mean, it's okay to take drugs, because see, it's only for a time period. You can take a beta blocker or whatever you are comfortable with and get over with it. But anyways, this feeling is okay, but still you don't realize that you remember a lot of things. It is just that anxiety makes you believe that you're forgetting everything. Second doubt that he had asked is, sir, what should I do in the last 10 days? I cannot revise everything. Now remember, this is true not only for FMG exam, but for NEET PG, INI set, any exam you are giving. Right, I am a firm believer of revising the whole content, right, at least one, quickly, in last 7 to 10 days. Right, and first of all, I'll tell you what is the advantage of that. When you go through the content, right, in the last 7 to 10 days, one benefit is what you have is the recent memory, right, and because of which you will not do silly mistakes, and you can easily, right, save 2 to 3 questions on the right side. Second, I mean, you'll get 2 or 3 questions more correct. What I mean to say is, second is, when you revise the content in 7 to 10 days going before the exam, what happens is your confidence level goes up. You feel invincible, and that confidence is something also is important going forward, right? So now coming to the question or the doubt that how can I revise in the last 7 to 10 days everything? Guys, you don't need to revise everything in the last 7 to 10 days. And I had been telling this for years altogether that how to revise in the last 7 to 10 days is something you need to prepare every day, right? Every day when you are preparing for the last 6 months or whenever, 1 year, whenever you're preparing. So you need to make small notes, concise notes, flow charts, the 20th notebook, whatever, anything it can be, so that you can quickly revise. If you have not made anything, then also okay, nothing is lost. Don't lose hope. At least when you look at your notes, you have revised them multiple times by now, and you must have marked the cue points where the questions are asked, right? And so at least in the last 7 to 10 days, just what you need to do for a particular subject is flip through the pages of your notes and briefly overlook only those points which are high yield, right? And for example, as I today discussed, just look in entire antiarrhythmics, just look drug causing QT prolongation, just look amiodarone, just look adenosine, and these 3-4 points, and that's all, you're done with antiarrhythmics. In congestive heart failure, just look about digoxin, only one drug, that's it, you are done. So this is how you need to deal with each and every subject and briefly cruise through the entire topic. Now you might have a feeling that I'm not perfect before the exam, and that's fine. Believe me, there is no student, not a single student out there who feels that my preparation is perfect. Everyone would have a feeling, I mean not everyone, then at least 90% or 95% would have a feeling that if I had one more month, I could have done it better. And believe me, even after 1 month, you would have the same feeling that if I had another 15 days or 20 days. So it's never about total perfection. It cannot be 100% perfect. What we are aiming to achieve is near perfection. So as much as perfect it's possible you can do, and just go to the exam, right guys? So many of you have requested me to upload the Pharmacast frequently, and I'll try to do that because see, I'm a one-man army, and I record these Pharmcasts, I edit them, I upload them, I post them, everything I do myself. Sometimes I have a difficult with timing, but I'll try to do that. So guys, 20th of Jan is the FMG exam, and 4th of March or 5th of March, I think it is the NEET PG exam. So basically the days are not that many more days are not left for your exam. So it's a every day schedule now, right? You have to push yourselves beyond the limit and keep going, right? And again, I always keep on telling you, the only thing that you need now is to have the faith in yourself, self-belief, that why are you preparing for the FMG exam or NEET PG? You're preparing for the FMG exam, you have to tell yourself, I am preparing because I will clear the exam. This positive mindset, it extracts more out of yourself. So you'll say to yourself, why am I preparing for the NEET PG exam? That is because I am gonna get a damn good rank. Yes, I'm capable of that. Tell that to yourself. Be positive, right? And you'll reach there. So guys, that's all for today's session, and keep hustling guys. I wish all of you all the best. Lots of love and blessings to all of you. This was Dr. Ranchan, your pharmacology faculty at Mero.